Okay, hello everyone. My name is Asher Kornbluth. On this tape, we're going to be talking about emergency medicine, the initial approach to the patient who's presenting to you anywhere, in fact, but most typically the question will put the patient in the emergency room. Let's look at the question at the beginning of this section. A 54-year-old man is at the opera when he suddenly jumps up, clutches his chest. He falls to his side into the lap of the woman sitting next to him. Now, let's make this an emergency medicine type question as opposed to just hysteria. And what do we have here? We have a patient who we're defining by this question is now unresponsive. And in any patient who presents unresponsive, before we begin to elucidate what the etiology is, whether it's a pulmonary problem, a cardiac problem, a bleeding problem, there are some basic approaches to the patient who is unresponsive. And you need to basically just memorize these. These are not always perfectly intuitive. You might think that something makes more sense to do earlier, but according to the guidelines we're going to review now, it might come later. So it's important to learn the guidelines and just memorize them by rote in terms of how to approach the patient who's unresponsive. The etiology, most patients who will have true sudden loss of consciousness, usually, but not always, it will be cardiac in origin. We'll talk about the various cardiac etiologies of loss of responsiveness and the various arrhythmias that can cause them. Very often it's in the setting of ischemic heart disease. Ischemic heart disease can trigger all kinds of arrhythmias. It can trigger ventricular arrhythmias, bradycardias, even asystole, and usually, but not always, a ventricular arrhythmia producing sudden loss of responsiveness or even sudden death will be of a cardiac ischemia in origin. But it could be many things. It could be a patient with severe congestive heart failure in whom the conduction system is stretched in a big dilated heart. There are many, many etiologies. Again, whatever the etiology, the first thing we're going to do is do the following steps to try and resuscitate the patient. Now, let's talk about what we need to do from top to bottom. The first thing you want to do is make sure the patient is truly unresponsive. You don't want to start performing CPR if somebody's just asleep or tired. Maybe this guy at the opera is just bored and he looks unresponsive, but he's really responsive. You don't want to start CPR, etc. How do you check if they're responsive? Well, you can give them a little gentle shaking. You do not want to shake them, especially upper body, especially the neck, if there's any possibility of a cervical spine injury. So anyone who seems to have sustained head trauma in association with the loss of consciousness, or anybody who has cervical spine tenderness, you're not going to start rattling them and shaking their head to the point that it might crack the cervical spine. There are various other maneuvers that we elicit pain. These are often popular among overworked interns and house staff, but they're often overdone. To determine if a patient's unresponsive, some gentle prodding will be fine. Calling the patient's name. We used to pinch nipples. We used to crack ribs. All kinds of barbaric stuff. That's not going to be one of the choices. You want to check if they're responsive. You want to make sure they don't have a C-spine injury before you start positioning them. So number one, check whether they're responsive or not. Number two is you're going to call for help. Now this might not seem perfectly intuitive. All you've done is shake the patient a little bit, see if they're responsive or not, and now you're running off to call for help. I mean, most of us would assume that what we're going to do first is check for breathing, the ABCs of resuscitation. That's not the case in terms of the ACLS protocols or the American Heart Association. There are, again, rigorous guidelines in which order you should do things in terms of taking the boards. Check for responsiveness. Number two, call for help. Why do you do that? Well, frankly, if you don't have an EKG and you don't have emergency access like intravenous catheters, medications, there's very little you're going to accomplish with pure, plain old chest compressions and breathing for the patient. So you're going to call for help. Obviously, if you're in the opera, you're not going to walk to the lobby and look for a payphone or find somebody's cell phone who's working. You're going to scream, get some help. What do you do then? You've checked the patient's not responsive. You've called for help in your panic. And now you're going to lay the patient on a firm and flat surface. Why is this? Well, you want to be able to deliver effective chest compressions. If you're pumping on a patient, and the patient, say, on a soft couch, you're going to be pumping the pillows. You need to have the patient in a position where your chest compressions will be effective. Now, again, I'm going to go over it again and again so it becomes ingrained. You check to see if they're responsive. You call for help. You've positioned the patient. Now you start doing your ABCs. Number one is you check to see that their airway is open. That doesn't mean you immediately are going to intubate the patient. And frankly, you probably don't have the means to intubate the patient at that particular moment. So you check to see if the airway is open. To maximize this, you could do the jaw thrust maneuver where you press firmly behind the mandibles, bringing the jaw out and up, and a head tilt, so you tilt the patient's head backwards. Again, be very careful if the patient has a C-spine injury. You don't want to crack their spine by tilting them backwards. The jaw thrust, the chin tilt are very effective to open the airway. That's A in the ABCs. Now you're going to check for breathing. We look for breathing. We see if there's any chest movement. We listen for breathing by putting our ear to the patient's mouth. And we feel for breathing. We feel to see if there's any air movement. And again, this is usually not that subtle. The patient will look flat and essentially dead from no respirations. Now what do we do? Again, rehash. Check for responsiveness. Call for help. Flat surface. Check the airway. And if there's no evidence of breathing, of spontaneous respirations, we're going to start our CPR. You're at the patient's mouth now. You've just looked, listened, and felt for breathing. So now the first thing you're going to do is give the patient 2 breaths. Then you're going to move down a few feet and start compressions if the patient doesn't have a pulse. So we've breathed for the patient after checking that they have no respirations. And now we're going to check for a pulse. We don't check here. We don't check for dorsalis pedis pulse. We check for carotids or femorals, big vessels in whom a pulse might be more easily palpable. And then we start our compressions. At what rate? Roughly 80 to 100 times per minute. Now, what's the ratio of how often you should be giving compressions versus how often you should be giving breaths? If you're the single resuscitator, the only person on the scene helping this patient, then you want to give 15 compressions, okay, at a rate of about 80 to 100 per minute, and then 2 breaths. If you're fortunate enough that someone else near you can also deliver some part of the resuscitation, then you're going to give 5 compressions and 2 breaths. Okay? That is the general approach for all patients whom you find unresponsive. We're going to talk now about VFib, VTAC, asystole, atrial arrhythmias, bradycardias, pulseless electrical activity in just a few minutes. All of these will be totally familiar to you. And again, by rote, you're going to know exactly where to go. On the boards, these are basically giveaway questions. There's no figuring anything out. You read the question, you determine what their etiology of unresponsiveness is, and then you do the appropriate ACLS maneuvers. So again, let's just review our approach. Number 1, check for responsiveness. Number 2, call for help. Number 3, patient should get on a flat, hard surface. When I say they should get on one, you're not going to ask them to rise and get on themselves. You have to position the patient carefully. Again, remember the C-spine, the potential for a C-spine injury. Next, you start your ABCs. Airway. And you could tilt the jaw, tilt the chin, jaw thrust, or tilt the head back. Next, just think of it, you're at the patient's mouth right now. You're going to give the patient 2 breaths. Okay? And frankly, even in this day of widespread communicable infectious diseases, when you're sitting at the opera, you don't have an ambu bag with you. And if you do, I'd wonder why you have one with you. But if you don't have any equipment, you're going to put your lips to the patient's lips, pinch the patient's nostrils, and deliver the breath. Nothing elegant about that, but potentially life-saving. You give the patient 2 breaths, check for the pulse. All right, so here's our A, B, and C, which is circulation. All right? Once we've done that, we know the patient has no pulse. It's time to get the pulse moving. We get the heart pumping, hopefully, by chest compressions. And by this time, hopefully, help is on its way. Now, let's go to the next case. And again, as we go through each of these cases, this will apply to every patient who you find unresponsive. Okay? These patients will probably not present to you on the boards in the emergency room. They'll have you walking along the street, being at some event, etc., where you find the patient such as this. The next case, a 54-year-old man is at the opera when he suddenly jumps up, clutches his chest. He falls to his side into the lap of the woman sitting next to him. After confirming that he is unresponsive, opening the airway, performing chest compressions and ventilation, an EKG arrives and reveals no evidence of electrical activity. So what do we have here? Did all this, got an EKG, and we have no electrical activity. What diagnosis does this define? This obviously defines asystole. Now, it might sound silly, but it would be awfully embarrassing if you call a patient asystolic and start some elaborate resuscitation methods and the cord to the EKG is a little faulty, or the leads are not plugged firmly into the EKG. So do simple things. If they ask you to confirm lead placement, that leads are all inaccurate, that's the right thing to do. Flat line is flat line. Now, occasionally, you can have a little bit of sort of background noise. That's probably from the machine more than anything. And as we'll see in a minute, this can represent VFib. But in general, on the boards, they're not going to ask you to decide whether this is VF, ventricular fibrillation, or asystole. Because frankly, there's no way to know. They're going to give you an EKG that looks pretty much like this, asystolic. What does that mean? There's no electrical activity. The patient's unresponsive, doesn't have pulse, so the patient has neither electrical activity of the heart or mechanical activity. All right? And again, we did all the first basic life support things. We got the EKG. This is what we see. All right, so now it's coming up to the point where we need to think about what protocols we use for the various arrhythmias. Again, most of these patients who are asystolic will have some history of coronary disease, and often this happens in the setting of severe ischemia. But again, it can be of many varieties. And frankly, if you find a patient unresponsive, who has been unresponsive for some time, remember the end result of all of us at some point in our future is this. Whether we have VFib before it or VTAC before it, this is what we all have in common at some point in our lives. Okay? So remember, this could be a final common pathway. This doesn't tell you very much about what caused the patient to die. So clinically, how does the patient look? They look dead, and their EKG looks like this, period. Not a subtle diagnosis. Again, when you're checking the EKG, in terms of making the diagnosis, you want to make sure that you've checked it in more than one lead to make sure it's not a lead placement issue. Again, I don't want to belabor this point, but if they give you any kind of choice, that sounds sort of silly, like check the EKG or check the leads are on. It's an appropriate choice. Now we're going to start CPR, which again is everything we had on the first blackboard. The basic life support has already happened. We have the EKG. We're doing CPR already. That's in our initial algorithm. And now we put an IV into the patient. Then I say, do I put an intravenous in or do I intubate the patient first? Again, you might think that in reality both of these things are happening simultaneously. But again, in terms of a protocol, you want to memorize the exact sequence of events. IV before you intubate. Think about it. The patient is already getting respirations from someone who's doing CPR. So that part is covered. You have nothing, though, to fix this. You need to get meds in there. You need to get the meds from the protocol into the patient. So you put the IV in and you prepare for intubation. Now, in a patient who's asystolic, what are the meds we're going to give? Epinephrine, IV, and atropine. And we're going to do this as we continue our resuscitation efforts, Q3 to 5 minutes. How much epinephrine? There's some controversy. They probably won't ask you to pick between different appropriate doses. What are the appropriate doses? 1 milligram is the standard answer for years. Some people, some guidelines now suggest using 0.1 milligram per kilogram. So a 70 kilogram patient or dead person will get about 7 milligrams. all right? And some people just recommend 3 to 5, 3 to 7. Anything that sounds like 15 or 20 milligrams is wrong. Anything that sounds like 0.2, 0.5 milligrams is wrong. It's going to be in this range. Atropine, 1 milligram. Okay. There's some controversy about whether bicarb should be used. And the controversy exists basically for each ventricular disturbance where the patient appears dead and might develop a severe acidosis. Bicarb will always be the wrong answer if you ask what's the first step in therapy, all right? And bicarb will be wrong all the time if the patient has a very brief period of asystole before they're discovered and resuscitated and don't have an underlying acidosis. The only time I would think about using bicarb definitively is if I know the patient has a severe underlying acidosis. Let's say I know they were in septic shock beforehand. I know the patient has had severe renal failure and hasn't been dialyzed. If the question gives me clear evidence that the patient is severely acidemic going into the code, into the cardiac arrest, then bicarb would be appropriate. But again, it's not the first step. If you want a pH number, I think everyone would agree under pH of, say, 7.1, an ampule of bicarbonate is appropriate. But on the other hand, if the pH is 7.25, 7.3, bicarb will always be the wrong choice. Okay. So that covers that covers asystole. Let's move on to our next case. The same 54-year-old guy who's doing a lot of jumping and a lot of falling. Jumps up, clutches his chest, falls to his side, keeps falling in the same place. He likes the lap of this woman next to him. He's not breathing. After confirming that he is unresponsive, opening the airway, performing chest compressions and ventilations, an EKG arrives and reveals ventricular fibrillation. He has no spontaneous respirations. Okay, now, first of all, this question has appeared on the boards. What's the most common cause of sudden death? VFib. 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 Accounts for the largest number of identifiable causes of sudden death. What does VFib look like? Well, there's no two VFibs might look alike, but they basically all share the fact that there is electrical activity and it's certainly not organized. It can be like this, it can be fairly fine, or it could be pretty coarse. And I'm exaggerating this obviously, but you get the picture. Nothing here is in an organized fashion. How does the patient look? They look dead. They look identical to the patient who's asystolic because this does not generate any contractions of the heart. This will not generate any pulse. This will not generate sufficient blood flow to go anywhere. All right, this is essentially equivalent in terms of its ability to cause contractions of the heart. This does not cause any mechanical activity. It's useless electricity. Now, let's talk about how we manage the patient for VFib. What is our protocol for ventricular fibrillation? Usually, but not always, these patients will have underlying cardiac disease. Usually, but not always, ischemic in origin. Now, what is our protocol? Again, simple questions here because this is pure memorization. You did your basic life support. You now have an EKG. You're continuing to perform CPR, and then you start shocking the patient. Shock, I don't mean surprise them. Shock with electricity. Real juice. You cardiovert them. And you give them 200 joules. You place the pads on the chest so you get adequate conduction of the shock, and you deliver the paddles to the chest. You're going to give them 200 joules 3 times in a row. After each shock, obviously, you step back and look at the EKG and see what's happened. If that doesn't work, you go to 300 joules. If that doesn't work, you go to 360 joules. Okay? So again, what we're trying to do is shock that minimal ventricular activity into a little bit more activity and hopefully organized activity. Now, we've given the patient all this cardioversion. The lights in the hospital are starting to dim. The opera house is going black because of all this electricity we're delivering to the patient. Notice that as we were doing CPR, we stopped, obviously. You don't want to have some poor schmendrick sitting there compressing while you're delivering all the electricity inches away from this guy's fingers. Remember, you stop CPR because this is so important. After you've done this sequence 203 times, 300, 360, then you got to try and resuscitate the patient some more. Again, you resume CPR. All right? Does any of this require an IV? No. This requires a chest and an outlet. This requires a couple of hands and some lips to deliver CPR. We still don't have an IV in this patient. Now we place the IV. Again, I'm stressing what sounds like simplicity, but some of us might say, oh, we can't do anything until we put an IV in. Wrong. Right? Putting the IV in here will not cause the chest to compress the heart. Doing this might give the patient electrical activity. Giving this might give the patient some mechanical pumping. This is now our next step if this doesn't work, because now we want to deliver some medications to supplement what we've failed to do with our electrical cardioversion. And what we do here is give epinephrine. Again, IV, and we give it in the same doses as we used in the patient at asystole. 1 milligram or 0.1 milligram per kilogram. The easiest number to remember is 1 milligram. We sort of try to stimulate the heart with a little pharmacodynamic support, and then we start shocking again the patient. We go, since we've already been up to 360, we keep giving the patient 360, give him a couple shots of it, and then if this is not working, we're going to start putting some anti-VFib medicine into the IV. Lidocaine, amiodarone is a reasonable choice, procainamide is a reasonable choice. And for sake of step 2, you don't have to remember doses of these. And this is basically the approach. So now we've given our ventricular anti-arrhythmia medication. I want to once again try shocking the patient with 360 joules. Okay? You can consider using magnesium here. We're talking still about VFib, but again, it's certainly not anywhere near the primary things we're going to do. All right? When is it appropriate to use bicarbonate? This question comes up again and again in every patient who presents unresponsive with one of these life-threatening arrhythmias. Again, the same guidelines I discussed before apply here in terms of using bicarb. If the patient is severely acidemic and you know that going into the arrest, or it's been a very prolonged resuscitation period, let's say the patient's been out in the field, the ambulance has brought them in, it's 30 minutes in, it's really not, there's nothing wrong with giving bicarb. But again, look at all the stuff we're doing first. Bicarb is not a primary treatment unless the question tells you, and this won't be subtle, that the patient is an overdose patient, specifically with a couple of kinds of overdose. And we'll talk about this when we talk about overdoses. Bicarb in patients who have phenothiazine overdose or aspirin overdose. All right, there it's essential. Okay, and we'll talk more about this obviously when we get to the overdose section. In terms of primary use during a cardiac arrest, it's way down on the list and only under those special circumstances. Okay, let's go on to our next case. Our 54-year-old opera lover jumps, clutches his chest, heads straight for the lap of the woman sitting next to him, but he's awake. He's in her lap and he's awake. But he's awake, but he's disoriented, and he's confused. He doesn't know why he's in the woman's lap. He's complaining of dyspnea and lightheadedness in his confusion. His exam reveals jugulovenous distension and a blood pressure of 114/80. The EKG shows ventricular tachycardia at a rate of 180. Okay? Now, the question is told us ventricular tachycardia on the exam. You probably won't be told that the patient has ventricular tachycardia. They'll show you a picture of the rhythm that's in your handout, in the syllabus, that is ventricular tachycardia. Now, ventricular fibrillation is pretty straightforward. Patient is dead with some squiggles on their EKG, and they're dead. No pulse, no breathing, dead. Here, the patient has a different kind of spectrum of activity that you might observe in this patient. Patient might be dead, or the patient, as in this question, might be alive in this woman's lap. So how do we approach this? Here we need to have a more branching in our algorithm. And the first question is the patient responsive? Is the patient awake? Because you can have bouts of VT that are short-lived, maybe just 2 beats of VT doesn't count, but 3 beats of a wide complex tachycardia you should consider as ventricular tachycardia. If people are wearing Holter monitors, we frequently see in otherwise asymptomatic people, asymptomatic from the point of their arrhythmias, we frequently see little runs of VT. When do we call it, quote, sustained VT? If it lasts for more than 30 seconds. All right? And if it lasts for more than 30 seconds, more frequently than not, the patient will be at least symptomatic, lightheaded, dizzy, confused, disoriented. And obviously, as it goes on longer, it becomes less and less likely that the patient can sustain consciousness. Now, and again, you're going to see the EKG. And I will call this VT. It's a wide complex. In other words, greater than 0.12 seconds. I don't see any P waves here. This is purely a ventricular rhythm. And the rate is usually at 160 to 240. All right, it's not always the case. There's something known as an idioventricular rhythm where the rate might be considerably lower, but for the sake of the boards, for step 2, consider VT usually occurring at this rate. Wide complex, no P waves. Every P wave here is, every QRS here, there are no P waves. Every QRS is identical. So this can be called monomorphic. One shape. On the other hand, if I drew you a patient's EKG that looked like this, you get the picture. You have polymorphic types of QRS. Wider than 0.12 seconds, it's rapid, but this is the baseline on the EKG, there's twisting around the baseline, or twisting around the point. And for those of us who speak French, you'll have to excuse my accent. And this is called torsade de pointe. Okay? Torsade de pointe, to say with the proper French accent. And this means twisting around the point. This has to be recognized. And it's an easy question, because it's easy to recognize, because the treatment here will be different. Okay? And we'll come back to the treatment of torsade in a moment. Let's go back to the more common monomorphic. This is polymorphic. And again, except specific clinical situations on the boards, the standard sudden death VT patient looks like this. And we'll talk about what situations you should expect to see torsade. Question here is the patient stable or unstable? If the patient is stable, VT, stable patient. Let's say the patient is stable. That's what the premise we're working with now. Stable does not mean necessarily that the patient is wide awake, alert, giving an accurate history. This guy is lying confused in this poor woman's lap. The woman might be unstable, but right now the patient looks hemodynamically unstable. Hemodynamically stable. Okay? What do we do? Well, the patient's in sustained VT. We got the EKG on this patient. And it's obvious that he's awake, but he's disoriented. He has a pulse. He's obviously breathing. This patient is stable. Do I want to leave him like this? No. Obviously, I want him hemodynamically stable, but I don't want to leave him in VT. Because if you stay in VT long enough, you're going to end up, obviously, hemodynamically unstable. But again, here I'm not going to shock the patient. Patient's awake and alert. Here I'm going to try my intravenous medications, lidocaine, amiodarone, procainamide, etc. Okay? On the other hand, if the patient is hemodynamically unstable, and hemodynamically unstable refers to a patient who's developing hypotension and shock, a patient who is extremely breathless, presumably because they're going into pulmonary edema, all right? A patient who's losing their mentation because there's not proficient cerebral perfusion. These are our hemodynamically unstable patients. A patient who might be awake but having severe chest pain because they have no coronary artery flow, because there's no effective, or there's not sufficiently effective heart pump function. So in the hemodynamically unstable patient, we have a protocol that we're going to follow. And it is basically very similar to our VF protocol. In fact, it's identical to our VF protocol. Okay? There are some exceptions to this rule, and that in terms of the protocols used. And that is the patient who has torsade. Now, torsade rhythm's easy to recognize. Here you want to give the patient magnesium. Magnesium is not at the top of the list on our VTAC or VFib protocols. We're going to give the patient magnesium, and we're going to perform the rest of our protocols. We're also going to try and think about what underlying cause this patient may have. The question might say, this is the patient's rhythm. What is the most likely cause? Think about torsade in association with a long QT interval. What gives this? Anticholinergic overdose, phenothiazine overdose, various medications such as quinidine, procaine can prolong the QT interval. All right? Now again, we use quinidine and procaine in patients who have VFib and VTAC, monomorphic VTAC. But however, patients are on this medication for other reasons. These are commonly used for atrial arrhythmias, chronically. And if the patient for some reason has an overdose of these, and it might not be a suicide attempt, it might just be that they're not excreting enough of it, maybe their renal function is diminished, etc. The question will put this in the patient's list of medications, and then the patient has sudden death, and then they give you this EKG. The cause will be this. They'll give you a lot of other history. Patient has a history of ischemia, congestive heart failure, atrial fibrillation. Always look at the medication list. If this is on the list and the patient has sudden death, what you're going to look at is the QT syndrome, the prolonged QT producing the torsade. And you're going to use magnesium early in your protocol. The last point I want to make is if the patient with VT survives, and again, these patients can very well survive. They might even be awake and somewhat alert when you first meet them in VT. But if they've had true sudden death, again, usually in the setting of severe cardiac disease, you'll see this, ischemic disease, if they have sudden death before they go home, I don't mean home from the opera. These patients obviously going from the opera to the hospital for a little while. Before they go home from the hospital, they should have electrophysiology studies and be placed on a anti-arrhythmic for life. And if the presentation has been sudden death, they get an automatic implantable defibrillator. Automatic implantable cardiac defibrillator. Why? Because if they had sudden death once, they could have it again, and this should go off, and it gives the patient the shock. All right, this is programmed to detect when the patient has VT. It goes off, the patient gets a jolt, and hopefully comes back to sinus rhythm. Unfortunately, these things sometimes go off even when the patient's sitting in sinus rhythm. It's a little bit alarming to the patient, quite painful, and these things often need to be reprogrammed. But this is not experimental. This is now standard for patients who have had sudden death with their VT. Okay? Automatic implantable cardiac defibrillator. If the patient has had ventricular tachycardia without sudden death and fails to improve with your anti-arrhythmic therapy, and this is discussed in cardiology because at this point we're talking beyond the emergency situation. If the patient does not respond to anti-arrhythmic therapy, they're going to get an AICD. If they have sudden death, they're going to get AICD. Okay? So that's our approach to the patient with ventricular tachycardia. Again, think of it in terms of whether the patient's stable or unstable. The stable patient, start an antiarrhythmic intravenously, try to break their VTAC. If it's VTAC that is hemodynamically unstable, treat the patient as you would VFib. Let's go on to our next case, which is a patient with pulseless electrical activity. We don't have the case necessarily in the syllabus, but again, it's our hysterical 54-year-old, leaps up, grabs his chest, drops into the lap, and we do all the basic life support things, etc., etc. The EKG arrives, and we find the patient has a beautiful rhythm. Patient might have normal sinus rhythm, sinus tachycardia, might have a ventricular arrhythmia too, but pulseless electrical activity means the patient has some form of an organized rhythm. It might be at various rates, it might be various rhythms, but it is a narrow complex, not a ventricular tachycardia, a narrow complex rhythm that seems organized. But yet, the patient is lying there unresponsive, essentially dead. They're pulseless, even though they have electrical activity on their EKG. Now, why should that happen? Why should we have good electrical activity and we don't generate a pulse? Again, we're not feeling it at the radial, we'll feel it at the carotids or the femorals. They're pulseless because even though the electric activity works, the pump isn't pumping. So there's no contraction. Now, in passing, I mentioned what is the cause of all the arrhythmias we've discussed so far. And I mentioned in passing because we're not going to start treating the patient who's in VTAC with nitroglycerin for his ischemia. I mean, obviously, we've got to resuscitate the patient no matter what the cause of their VTAC or VFib. In a patient with pulseless electrical activity, it's essential to know why they have electrical activity, but the pump isn't pumping. Okay? What are the causes? And the causes will determine what you do in the initial moments of the resuscitation of the patient with pulseless electrical activity. Well, let's say the patient is just extremely dry. I don't mean dry as in it's a hot day and they're thirsty. I mean exsanguinating. Maybe in the OR. Maybe from a massive GI bleed. The heart, for a while anyway, still has normal electrical activity, or at least organized electrical activity, but there's nothing to pump out of the pump. And if you gave something to pump out, the pump might look like it starts to work again. Hypovolemia. Or, let's say the patient is in cardiac tamponade for whatever reason. And there are various reasons. The common scenarios is a steering wheel injury, a deceleration steering wheel injury, a patient who has had a pericardial fusion and now gets over-anticoagulated, etc. Whatever the cause of the cardiac tamponade, ventricular wall rupture with a severe anterior wall MI, whatever the cause, cardiac tamponade, even though the pump might have worked well just seconds ago, and there might be blood in the pump can't fill anymore because there's this tight pericardial sac tamponading it, putting pressure on it. So the heart can no longer fill to contract. Cardiac tamponade. What else? Again, in the setting usually of trauma, tension, pneumothorax. Where we see tension pneumothorax, one is obviously a high velocity steering wheel accident or any place where there's chest trauma, a knife wound, a gunshot, etc., or an iatrogenic tension pneumothorax, meaning we put in we tried to do a thoracentesis and we went a little too deep, caused a tension pneumothorax. How do we identify tension pneumothorax? Patient will have large neck veins, and no signs of heart failure, so the large neck veins is not because of heart failure, they will have change in the breath sounds. Obviously, the lung where the lung which has collapsed will be breathless. So you might hear breath sounds on the left. If the tension pneumothorax is on the right, you'll hear no breath sounds here. That defines a pneumothorax. What defines a tension pneumothorax? When that pneumothorax is under tension and things start to shift. So your cardiac apical pulse might shift. And in this case, you don't have a pulse. The patient will have, again, large neck veins. The patient's trachea may have shifted. There will be shift away from the typical location because the mediastinum is being pushed. And it can be pushed, obviously, in this way, too. All right? So tension pneumothorax. And again, the concept here in terms of the pathophysiology is like a tamponade. The heart is under too much pressure to fill and then contract. Tension pneumothorax. Where else can we have a situation where we have pulseless electrical activity? Pulmonary embolus. What's happening there? Well, in a massive life-threatening PE, all right, in a massive life-threatening pulmonary embolus, there's an embolus, there's a clot in the pulmonary artery. And either the mainstem pulmonary artery or right where the artery branches off into the left and right mainstem pulmonary arteries, there is such a huge clot there that blood leaving the right ventricle and circulating through the pulmonary circulation meets this big roadblock and nothing gets through to the left ventricle. All right, so the ventricle might be intrinsically normal, but there's no blood being delivered, so the pump doesn't pump. There's nothing in there. Okay? Now, why and how we determine this? Well, on physical, there might be minimal signs when the patient is already dead. But the question will tell you that the patient has a history of deep venous thrombosis. The question will tell you the patient has a history of pulmonary emboli. The question might tell you that the patient is severely hypercoagulable. All of these instances should suggest pulmonary embolus. Now, why is it so important? Why am I spending all this time telling you about these important different etiologies? Again, because it will influence how you manage the patient. The patient has electrical activity. I don't need to give epinephrine or atropine. I don't need to give ventricular antiarrhythmics because I have a normal-looking, narrow, complex rhythm that's organized. But I need to get fluid into that pump so the pump can pump. If the patient's massively exsanguinating, massively bleeding, I pour fluids into this patient. I want to fill the tank. If the patient has cardiac tamponade, and the EKG will have an electrical activity, but it'll be very low in voltage. The tamponade will be clear from the question. They'll give you some cause for the cardiac tamponade. What you're going to do here is take a needle and do an emergency pericardiocentesis. Put a needle in under the xiphoid process, aim for the left nipple, and hopefully you're going to draw back some blood. Obviously, you stick the needle in far enough, you're going to draw black blood from the ventricle. But you want to see it come out from the pericardium. That's where the blood should hopefully be coming from. And the way you'll know that you've done a successful pericardiocentesis is because the patient regains their pulse. You've alleviated that pressure about the ventricle could finally open up, expand, fill during diastole, and start pumping. And then the patient obviously have to go for a more formal pericardiocentesis in the OR, but this can be life-saving. Hypovolemia, hydrate, fluids, blood, whatever they need. So this needs fluids. Cardiac tamponade, pericardiocentesis. Tension pneumothorax, again, the heart is under pressure, under tension. I want to relieve that tension. What do? Do a needle thoracentesis. If it's on the right side that there's no breath sound, put a needle in here. I'll have a gush of air. The patient will dramatically improve. The neck veins might come down. The pulses may return. So I'm going to put in a chest tube or do a needle thoracotomy. That's tension. And a pulmonary embolus, hopefully, it'll be clear that the patient has a pulmonary embolus by the history the question describes to you on the exam. And this patient, by definition, has pulseless electrical activity. This is obviously a life-threatening PE. This is the kind of patient who I want to try using fibrinolytics to lyse that huge clot. Okay? Fibrinolytics, or even on rare occasions, an embolectomy. And that's the only time you're going to use this very potent fibrinolytic type of agent In a patient whose pulseless electrical activity, they might have fallen, they might have hit their head. Remember, fibrinolytics can make you bleed from tiny little areas of trauma. You're only going to use this if the question has made it clear that they have a pulmonary embolus. And they might show you on the EKG, S1Q3, T3, a prominent S wave in lead 1, a prominent Q wave and T wave in leads 3. And they might also show you on the EKG signs of right ventricular strain, right ventricular overload in a patient with a massive PE. Because again, the right ventricle is trying to push blood through that blocked pulmonary artery and develops right ventricular strain. Again, there's not going to be anything on the lung exam that will tell you your patient has pulmonary embolus during an episode of pulseless electrical activity. Okay, once we've identified the cause of our pulseless electrical activity, we try and treat it, and then we're going to embark on CPR, put in the IV, intubate the patient, and only then start the patient on some epinephrine. And again, keep looking for the underlying cause. If a patient has pulseless electrical activity, I can virtually guarantee you the question will make it clear which form of these etiologies the patient has, and they will want you to treat appropriately. Give the fluids, do a pericardiocentesis, put a needle in the chest, and if it's a massive life-threatening PE, fibrinolytics. And we're going to take a short break here and resume with atrial arrhythmias. Okay, so we've talked about the sudden death pictures, the ventricular fibrillation, the ventricular tachycardia, the pulseless electrical activity, those things that typically will present with a dead patient. Let's talk about arrhythmias that we might need to manage in an emergency situation, but typically less urgent, less life-threatening. And I'm talking here about atrial arrhythmias. And when we talk about atrial arrhythmias, for the purpose of this talk, emergency management, we're basically talking about 3 rhythms: atrial fibrillation, atrial flutter, and supraventricular tachycardias. And obviously this is discussed in greater detail in cardiology. Here we're interested in the immediate emergent management of these patients. Atrial fibrillation, there is a undulating irregular baseline. It's fibrillating. If the whole cardiogram looked like this, we'd say it's VFib, but this is a fibrillation limited to the atrium. So there is no effective P wave, there's no effective atrial contraction, but we do see normal QRS and T wave. And between the QRS, we have this irregular fibrillating atrium. And you can see from this that this is irregular, and furthermore, it's irregularly irregular. In other words, if I gave you a stethoscope and you were listening to this, you might hear beat, 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 beat. There's varying time between the QRS, very typical of atrial fibrillation. Atrial flutter, on the other hand, there's more organized atrial activity, and it tends to be more regular. And here again, there might be some difficulty sometimes, but not on the boards, discerning between, let's say, a fibrillating atrium that looks somewhat regular and the more regular flutter waves. Atrial fibrillation, there's no contractions going on in the atrium. In atrial, and the messages being sent to the AV node are coming from all different spots in the atrium. Atrial flutter, there's usually a single focus in the atrium that has these ineffective atrial contractions, and eventually you'll get a QRS. This tends to be more regular. Both of these, as well as the SVT that I'll discuss in just a few seconds, present with fast heart rates. These are tachycardias, and very rarely bradycardias, very rarely bradycardias. And so really, if this was on a cardiogram, all your QRSs will look closer together. How quickly do they run? They can run anywhere from 120 to about 200. AFib, aflutter, what unifies them is the fact that they have normal conduction through the ventricular conduction system. So you have a nice looking QRS and T wave. Nice looking. Now, SVT, supraventricular tachycardia, actually let me make a little room here, is most frequently due to something known as the AV node reentry tachycardia. And usually AV node reentry tachycardia. If this is your sinus node, and this is your AV node, and this is your bundle of His, what happens is there is a normally conducted P wave to start this whole cycle. It comes to the AV node where there is a delay. That's the job of the AV node, is cause a delay. Then the rhythm, the conduction, does not leave down the usual pathway, but takes a path like this and rejoins this pathway, which then conducts back up to here. And this happens quickly and repeatedly before P waves are coming through, and this gives you that tachycardia. It is typically without regular organized P waves. Often there are absolutely no P waves. That would be the typical pattern I would expect on the board. And there is just a tachycardia, normal QRS, very regular. It's most typically an AV node reentry tachycardia. So we talk about AFib, aflutter, and supraventricular tachycardia, usually, but not always, AV node reentry tachycardia. How do we manage these now? We've talked about their clinical presentation, which can be very broad spectrum. Patients may be entirely asymptomatic and have periods of AFib, aflutter, or SVT. Obviously, those patients are not going to be in any sort of danger immediately. You're not going to start doing the aggressive treatments we'll talk about in a moment. And the boards might give you a patient who comes in for non-specific complaints, or maybe a complaint that is entirely unrelated to their cardiac disturbance. Maybe they're coming in for an annual physical exam, and they'll say the EKG shows the following. And they'll show you a patient with atrial fibrillation, atrial flutter, or SVT. What they want you to do in that situation is to do nothing acutely. Nothing in terms of cardioversion, either electrically or pharmacologically. So the asymptomatic SVT, whether it's fib, flutter, or SVT of the AV node reentry type, if it's asymptomatic, you're not going to take one of these very aggressive approaches. And we'll talk in cardiology about the appropriate outpatient management of asymptomatic fib, flutter, or SVT. But on the boards, they might very well and more likely give you a patient who presents symptomatic. Now, what do the patients have when they have these rhythms? There's nothing specific about the clinical presentation. They might have very non-specific symptoms, a little dizziness, a little lightheadedness, palpitations. Remember, palpitations are not identical to a severe or life-threatening arrhythmia. You could have palpitations, and it could be hemodynamically perfectly stable. We don't treat the palpitations per se. We might treat them, as you'll again hear in cardiology, with things long-term to prevent that uncomfortable feeling of palpitations. But don't make more of the palpitations than as a symptom that there is probably some tachycardia. So those are the milder presentations, from asymptomatic to a little dizzy, lightheaded, palpitations. And now we could come to the more severe presentations where the patient has signs of hemodynamic instability because the ventricular rate is rapid. We don't get hemodynamic compromise merely because there is no effective atrial contraction in most situations. The problem is there's a ventricular tachycardia, diastolic filling time of the heart is shortened, and our cardiac output diminishes. The exception to when atrial fibrillation, the atrial contractions themselves, make a big difference is in a patient with severe underlying cardiac disease, and especially with mitral valve stenosis. where the patient depends on a very strong atrial kick, which is represented on the exam by the S4 sound. Patients with mitral valve disease, mitral valve stenosis, need that atrial kick to get blood through that very stenotic valve. So you need that atrial kick. And when the patient goes into AFib, those patients will typically have an acute exacerbation of their symptoms very quickly. But again, the symptoms are usually because there's not enough filling time. And why do I stress this, where the symptoms come from pathophysiologically? Because that'll help you remember that the first thing we want to do in the symptomatic, hemodynamically unstable patient is try and slow down the rhythm. My first goal is not necessarily to convert the patient to sinus rhythm. If the patient needs to be treated, the first thing I'm going to treat, if they are not very hemodynamically unstable, they're not hypotensive, they're not shocky, they're not having severe cardiac ischemia, and they're not developing severe congestive heart failure, I don't need to convert them instantly. The first thing I want to do is slow the ventricular response. I want to put some more blockade at the AV node, okay? Because whether the stimulus to the AV node is happening from all over, as happens in AFib, or one focus perhaps, as happens in A-flutter, or from an AV node re-entry in the typical SVT, all of them can be slowed if I block this further. Remember, the AV node will typically slow things down. I want to cause greater blockade here. Not so much that I have to rely on a ventricular response, and that's the toxicity of too much AV node blockade, is nothing gets through, and you'll see a wide, slow rhythm. We talked about slow ventricular tachycardia or idioventricular VT. This is where it might occur. Excessive blockade of the AV node. Now let's talk about what we use to slow the AV node. Well, it depends on the clinical situation. There are a number of agents, but the agent of choice has evolved to be adenosine, intravenously. The advantage of adenosine is that it starts working extremely quickly and is gone extremely quickly. So any adverse effects, and they're very uncommon with adenosine, are very short-lived. So this would be an excellent drug to try and block the AV node further and slow down the ventricular rhythm. We have other drugs, and in a patient who has underlying severe congestive heart failure, digoxin is a very good choice. Digoxin pharmacologically is nowhere near as clean as adenosine. There's a lot of toxicity associated with dig, as you know from the cardiology tapes. And this takes longer to have its onset. It's not within seconds or a minute or two. This could be several more minutes, and it can last for hours. So digoxin is not a clean enough drug to use in all comers. However, if they tell me that the patient has severe underlying heart failure or is in pulmonary edema now related to their SVT, digoxin would be an excellent choice. Other drugs that work, calcium channel blockers, and not calcium, but calcium channel blockers and beta blockers. And we said this is a good drug to use if the patient has severe cardiogenic failure, severe pulmonary edema. This is a terrible drug to use if the patient has underlying heart failure. And especially beta blockers. Calcium channel blockers, particularly drugs in the verapamil or diltiazem class, cause significant decrease in cardiac contractility. That's not what you want to do as you're trying to stop the SVT. So I would not use calcium channel blockers or beta blockers in a patient who has underlying heart failure in association with their AFib. There I would use digoxin. If they don't make any particular mention of heart failure, again, the cleanest drug to use in all comers is adenosine, except in certain situations where there's heart failure, then you use digoxin. Okay. This has all been about the acute management of SVTs. Let's talk a little bit about, and we've talked here about the management of the patient who is unstable. This has all been unstable. We're looking to get IV medications into the patient, again, not to convert them initially, but to slow them. These are all slowing agents in the unstable patient. So first thing you do is slow the patient if they're unstable. Adenosine is my first choice there, and that's what I'm going to look for on the exam. And obviously all these medications, the digoxin, the calcium channel blocker, and the beta blocker are given intravenously. How about if the patient's stable? Meaning they might have some palpitations, they might be a little lightheaded, but basically they have a normal blood pressure, they're feeling otherwise okay, and they're just a little uncomfortable from their palpitations. And it's AFib, AFLUD, or SVT. What's the management here? I don't need to put in IV adenosine yet. What I'll do is try and again, block the AV node, but I'll try and do it physiologically, without pharmacology. And what I'll do carotid sinus massage. I'll ask the patient to Valsalva. What is this doing? This is increasing vagal tone. And as you remember, the vagus nerve slows down and blocks the AV node. So if I could stimulate vagal tone with carotid sinus massage or asking the patient to do the Valsalva maneuver, I can potentially slow down, and in patients with a AV node reentry, if I slow this down enough, sometimes my carotid sinus massage might be enough to even break this and put the patient back into sinus. So the stable patient, carotid sinus massage. A couple of trick questions about carotid sinus massage. How do you do it? You do it only on one side after you've listened with your stethoscope. Make sure the patient doesn't have a carotid bruit. You're not doing a stable patient a favor if they have a big carotid plaque and you massage that plaque, slow the heart rhythm, but send that plaque into the brain and the patient strokes. So listen first, make sure there's no bruit. Don't press on both carotids at once. All right? There's no cerebral perfusion. You might as well put a noose around the patient. One side, without a bruit, carotid sinus massage, while watching the EKG, and you'll know you'll have an effective response if the rhythm slows down. Okay? That is our approach to the stable patient. Let's talk about what we do to convert the patient. We've talked about how slow the ventricular rhythm, that's step number one. We've slowed the patient, and now we want to convert the patient from their SVT to normal sinus rhythm. Give the patient back that atrial contraction, improve cardiac output that way. Slow down the rhythm, then convert. Now, there's one situation, which I didn't mention yet, where we're going to use cardioversion as the first step, before carotid sinus massage, or in the unstable patient, even before adenosine. And that is the patient who is very unstable, meaning they're unconscious, they're hypotensive, they're having severe ischemia. In the extremely unstable patient, I got to do something more than just slow them. In the extremely unstable patient, I want to cardiovert them. Synchronized, hemodynamically very unstable. I want to do synchronized cardioversion. Because those patients, if I know they have just now gone into their SVT and they are having a severe collapse because of that, I want to get them back into normal sinus rhythm. More than just slow them. Slow them is not going to be enough to get them out of shock. I want to get them back into an effective normal sinus rhythm. I cardiovert. And these are not the kind of power, the kind of juice we put into our patients with VF or VT. Here we start lower. It does not usually require 200 to 300, 360. This will usually start about 25 to 50 and see if that'll get the patient back into normal sinus rhythm. So again, thinking back to the unstable patient, if the patient is severely unstable as defined by shock, coma, I'm going to try and cardiovert the patient immediately, electrically. Okay? Now, in our other patients who are more stable, I want to take the patient from SVT to normal sinus rhythm. I can do that with an elective cardioversion, which involves giving the patient some sedation electively and then shocking them. Most patients will prefer that rather than trying to juice them back up into normal sinus rhythm, that we give them medications, and the medications are things like quinidine, procainamide, amiodarone, and there's a long list in the syllabus. And again, this is to bring the patient into sinus. All right? If the patient's very unstable, will you use one of these medications intravenously to convert the patient? No. The patient is very unstable. You need the most effective, which is electricity, cardioversion electrically with low voltage. Electively, you then can put the patient on one of these agents to convert them. Remember, the adenosines, the digoxins, calcium channel blockers, and beta blockers don't convert the patient back to sinus. They merely slow their ventricular rate, which is usually enough to get the patient out of trouble. If the patient's in severe trouble, they need their normal sinus rhythm, cardiovert them electrically. One other point, and again this is discussed in the cardiology tapes in greater detail, is the concept of anticoagulation. Anticoagulation plays no role in the emergency management of the patient who develops a sudden SVT. It is absolutely wrong. It'll probably be one of the choices, intravenous heparin or Coumadin, because you know that Coumadin has something to do with atrial fibrillation. What does it have to do with the management of atrial fibrillation? In patients who have been in atrial fibrillation for some time, and again, this steps us out of emergency medicine and brings us more into the chronic stable patient. In the patient who can tell you they've had palpitation for several weeks, days at least, days and even going on weeks, you don't want to convert them the minute you see them, because that fibrillating ventricle, the fibrillating atrium is not organized contractions. And in that fibrillating atrium, blood becomes prone to stasis. And when blood is static, not moving out in an organized fashion, those patients can develop clots, thrombus, which then break off and become emboli. All right? So you don't want to take a patient who's stable and been in AFib or flutter or an SVT for a number of days and immediately cardiovert them. Again, I'm defining a patient who they tell you is stable. There's reason to believe it's not new onset. That patient, if they're uncomfortable, you slow them. That's fine. And then you anticoagulate them for several weeks so that any clot that has formed over the preceding time becomes a mature, stable clot that is less likely to embolize. So that's when anticoagulation, typically with Coumadin, is used. That's in the stable patient who's had the SVT for some time preceding their presentation. They're stable, and you want to anticoagulate them to prevent any new clots from forming, to firm up any clots they already have, and then I can bring them back for either synchronized cardioversion, or as we said, most patients and doctors will convert them with medication. And again, all of these medications can be used intravenously in the unstable patient, and all of these medications are available in oral form as well. All right? And that's where anticoagulation fits in, particularly in the patient with mitral stenosis. If I see anticoagulation as the initial treatment for SVT, almost always going to be absolutely wrong. If I see a patient with mitral stenosis and they want to talk to me about chronic symptoms, chronic palpitations, Coumadin is the drug of choice to prevent the clots from forming. Okay. Let's move on to bradycardias. We've talked about the ventricular bad stuff. We've talked about fast atriums. Now let's talk about slow hearts. Bradycardia, strictly defined, pulse rates of under, say, 60. Now, does this mean patient presents in the office on the board with a heart rate of 48, 52, 46, and is in perfect health? The question goes to great lengths to tell you the patient is healthy. Furthermore, the patient exercises a great deal, and they'll give you 5 choices of what to do. Different stimulants to the heart, immediate pacemaker, atropine, etc., etc. Those will always be wrong. In the healthy patient with a sinus bradycardia, the answer is no treatment. And in fact, the healthiest hearts, the well-conditioned hearts, develop such good stroke volumes that they don't need to beat 70 times a minute. The heart, because it's such an effective pump, because of all that aerobic conditioning, the heart can get away with 40 or 50 beats per minute, because each beat has a very high stroke volume. And remember, cardiac output is heart rate times stroke volume. And if your stroke volume is excellent, you don't need as much of a heart rate. Your heart rate will generally settle down. If you look at the pulse rate of marathoners, they might be in the low 40s. Okay, and if it's sinus bradycardia, we do nothing. That will be the right choice in the asymptomatic sinus bradycardia. Now, That's one scenario, one question you'll see on the boards. And now let's move on to the patient who has bradycardia that needs treatment. And again, the patient can have a fairly non-specific clinical presentation from just a little lightheadedness, dizziness. If it's been going on for some time, maybe some sluggishness. If it gets more severe and the patient has a sick heart, they might not tolerate a very low heart rate because, again, stroke volume might be normal or even low. Having a slow heart rate does not help that patient. So if the patient is symptomatic, I need to fix that bradycardia. Now, what are the different kinds of bradycardia? We're going to talk now about bradycardias that are narrow complex bradycardias, and we're not going to talk about the much rarer slow idioventricular rhythms. Bradycardias can come in many different flavors. Sinus bradycardia, again in a normal heart, a lot of time between beats, can be perfectly normal. We're going to talk about patients who we do need to treat. And remember, this can be a normal finding. If they're symptomatic, acutely symptomatic and unstable, what do we need to do? The protocol for bradycardias that are producing hemodynamic compromise, or certainly hemodynamic instability, we want to treat with the anticholinergic drug. Remember, we talked about vagal tone at the AV node causes further block. This patient's going too slow. We want to decrease block. We want anti-vagal medicine. We want anticholinergic medicine, and that's atropine. If the patient is extremely bradycardic to the point of being pulseless or to the point of having minimal blood pressure, and we have to think about it as a potential arrest coming up to us, then we'll use epi as well. Epinephrine in the same doses we used it before. But again, some of these patients have underlying coronary disease. I'm not going to use the epi unless the patient is threatening to arrest. And lastly, I'll put the patient with a pacemaker. It could be an external pacemaker, it could be an internal implantable pacemaker, but the immediate treatment is going to be the atropine, epinephrine if necessary, and external pacing next. That's the approach to patients with bradycardia. And then you need to also figure out, why is this patient bradycardic? Are they on some medication that is making them symptomatically bradycardic? What are the medications that these patients will often be on? They'll be on things like beta blockers, perhaps for their hypertension or for their coronary artery disease. They'll be on calcium channel blockers for their hypertension or coronary heart disease. If the patient is asymptomatic on a beta blocker with a rate of 50 and they're well controlled in terms of their blood pressure and ischemia, that's a great heart rate for that patient. Same goes for calcium channel blockers. On the other hand, if they're on beta blockers and they're so lightheaded that they're having syncope, obviously I need to reduce that beta blocker dose. Obviously, initially I'm going to eliminate it and obviously treat the patient with a lesser dose. But again, acutely to get the patient pumping faster, atropine, epi, pacemaker. What are some of the rhythms that you'll see? Well, we talked about sinus bradycardia. Let's talk about the various heart blocks. There's first degree, which just means a long PR interval, greater than 0.2. And the heart might be going slow, or might even be at a relatively normal rhythm. That's first degree heart block. By definition, first degree heart block will never produce symptoms in and of itself. If a patient has a first degree heart block and they're on beta blockers, the question will be, should you lower the dose or stop the beta blocker? The answer is not really. You don't need to worry about first degree heart block. It might be a clue that the patient's on a medication that you're going to have to watch because you don't want the patient to progress. But first degree heart block requires no treatment. Next, what's second degree heart block, which now comes again in two varieties. Second degree heart block comes in the Mobitz 1 flavor, which is a PR that's somewhat long, and then that PR becomes longer, and then the P wave doesn't conduct. P wave here is a little long, wider here, and no conduction. And this can happen with different patterns. You might see this is called 3-to-2 Mobitz 1. 1, 2, 3 P waves, and only 2 QRSs. You might have 4 P waves, prolonging the PR interval before they drop the beat, and that would be a 4-to-3. Don't worry about the particular number of ventricular complexes in between the P waves. What you need to recognize in a Mobitz 1 is that the PR is gradually prolonging, and then you drop a beat. That's Mobitz 1. First degree heart block and Mobitz 1 rarely produce symptoms and do not require treatment if the patient is asymptomatic, which they will almost always be. How about Mobitz 2? This also, by the way, Mobitz 1 is Wenckebach. Now, Mobitz 2. You have a PR This is my T wave, P wave, QRS, P wave. That's my T wave, and then P wave, no conduction. The only difference on the cardiogram between a Mobitz 1 and a Mobitz 2 is that in the Mobitz 2, the PR interval remains constant, and then you drop a beat. Again, the pattern in terms of how many P waves before the drop beat can vary, but here, PRs stay uniform until you have a drop beat. This, in turn, it turns out, is a more severe arrhythmia than Mobitz 1. It's a more severe bradycardia. Patients are more likely to be symptomatic. Patients are more likely to progress to third degree or complete heart block. This is usually associated with the big MIs, the anterior wall MIs, whereas Mobitz 1, if it occurs in the setting of ischemia, is usually a smaller MI, like an inferior wall MI. Mobitz 1, no treatment. Mobitz 2 requires treatment. Acutely, if they're symptomatic and hemodynamically unstable, atropine, epi, pacemaker. Okay? And if they're not terribly symptomatic and they don't require acute care, they're going to need a permanent pacemaker. All patients with Mobitz 2 get permanent pacemakers for all intents and purposes for the boards. Unless it's a very short-lived phenomenon in the setting of an MI and they quickly come out of it. But for all intents and purposes, if they're telling you a patient has Mobitz 2, and they'll tell you that because the cardiogram looks like this, consistent PR intervals, and then a drop beat, they want you to put a pacemaker, a permanent pacemaker in this patient. So again, first degree heart block, no treatment. Second degree heart block, Mobitz 1, no treatment. Mobitz 2, treat. Atropine, epi, acutely, pacemaker. And let's move to third degree heart block, where now, you have to look carefully at a patient with third degree heart block. It will be in the setting of underlying severe cardiac disease. Patients rarely, except rare congenital diseases, which I'm not talking about pediatrics. In the adults, it can look like flutter waves. A third degree heart block can look like atrial flutter. What's different is first of all, the QRS complexes are further apart. Atrial flutter, remember, happens with rapid heartbeats. It was one of our discussions of a supraventricular tachycardia. In a patient who is having complete heart block, it looks like they're regular P waves, and that's true. There's a P wave, P wave, P wave, P wave. And look at this Q, the ST looks a little deformed, and that's because there's a P wave in there. And then there might be a P wave in here, and this is an abnormal T wave. P wave, P wave, P wave. We don't see a regular PR interval because the ventricles are contracting on their own rhythm. So there's what's known as AV dissociation. The atrium might have electrical activity, and it's regular. But there's such high degree block at the AV node that nothing gets through. So you'll get a ventricular escape rhythm. And remember, the lower down you go in the conduction system, and especially when you're coming outside of the conduction system, the slower, and if you're outside the conduction system, the wider the QRS. So you'll have regular flutter waves, but you'll distinguish it clearly because the rhythm in the ventricles is slow, as opposed to atrial flutter, where it's fast. Furthermore, they'll usually show you P waves are sort of marching through the EKG. They happen regularly. And if it's time for a P wave to happen on the QRS, then the QRS might look not that abnormal, but the QRS might look a little abnormal. I'm exaggerating this, but I want to make the point that third degree heart block, regular atrial P waves, regular ventricular complexes, but the P waves ain't talking to the QRS. QRS is doing its own thing. Fortunately, it still has a reasonable rate to maintain consciousness, usually. But remember, third degree heart block is by definition an unstable rhythm. Patients won't be asymptomatic for long with this. They typically on the boards will come in with syncope with this, or hypotension. These patients acutely atropine in epi, and these patients will all need pacemakers. Okay, so that takes us through our bradycardias. And this concludes our discussion of the cardiac irregularities that we need to manage emergently.